A very good morning, everyone. This is Dr. Singaram. Welcome to the topic of big discussion. So today's topic I have taken up is torch infection, which is a very important topic for whatever exam you are appearing for, whether it's a competitive exam or a university exam. Definitely, you can get questions on this very important topic of torch infection. One of the very important reasons being more and more of infection has been added to this group of torch infection. As you all know that torch infection is an acronym for certain set of infections which are transmitted intrauterine, or what we call it as congenital infections. So torch infection is an expansion which stands for T for Toxoplasmosis, O for others, R for rubella, C for cytomegalovirus, and H for herpes. This others is the ever expanding group. Okay, we all know some typical examples which include syphilis, right? Syphilis, and we know that herpes zoster also included in this, or the chickenpox, and something which is very recently included, that is Zika virus. This is what we expand as torch infection. Of course, there are so many other infections also, but I have taken up the common ones. I'm going to discuss it today, right? Okay. So let us look at some general features of this torch infection, right? Now there are specific set of features, as you all must be knowing, but what I am going to tell you is general to every infection. Okay, there will be some exceptions as we will be discussing, but these are the general things you need to remember. The risk of congenital anomalies. Always remember, a problem with a torch infection is the occurrence of congenital anomalies in the baby, right? And when is the risk period high? If the transmission occurs in the first trimester, without any doubt, first trimester should be the answer, because first trimester is the time for organ formation. So that is why any problem encountered in that trimester is going to result in high risk of congenital anomalies. In general, I'm going to tell one more point, that the risk of transmission is also highest in the first trimester only, but there are certain exceptions which I'll be discussing under the individual infections, right? Okay. Now look, next let us look at the common manifestations of this intrauterine infections, right? Now I have divided it into antenatal and the neonate. Okay, in the antenatal period, it can be associated with abortions. Here, I would like to highlight a very important point, right? There is something called as a recurrent abortion. Recurrent abortion is generally not a feature of torch infection, except only one torch infection. What is that? That is syphilis. All the other infections can be associated with abortion, but only one time. But syphilis is known for a recurrent abortion or miscarriage. That's an important MCQ point which they keep asking in your exams. The second feature, it can be associated with intrauterine drive, intrauterine death, IUGR, or prematurity. But commonly, it is usually IUGR, which is fairly a common association compared to the other things in the antenatal period. Okay, so if they ask you which is the most common association of torch infection in the antenatal period, it is intrauterine growth restriction. That's also an MCQ point to be remembered, right? Now, as a pediatrician, what I am more concerned is about the features which are going to be present in the neonatal period, right? So I have listed up certain features, as you can see from the list: jaundice, hepatosplenomegaly, and thrombocytopenia. Now, the point to be remembered here is that these problems are going to occur only if the infection was very severe, right? Only in a severe torch infection only you are going to encounter these problems in the neonatal period, right? Number 2 point you need to remember is that this jaundice, hepatosplenomegaly, and thrombocytopenia could also be a manifestation of a common problem which you can encounter in the neonatal period. Common means when comparison to the torch infection, the problem I am going to tell you is more common, and that can also have presentation with jaundice, thrombocytopenia, and hepatosplenomegaly. So what is that differential diagnosis which you should always keep in your mind when you're evaluating a suspected torch infection? It is sepsis. It is neonatal sepsis. So please remember, sepsis is one of the very important differential diagnoses for torch infection. So that is why you should always, while working up an infant for torch infection, you should also parallelly work up for sepsis also, because that can result in the death of the baby also, right? Okay. Now, having seen about the common features of intrauterine infection, let us now look at individual infections. Right. Now, rubella or congenital rubella syndrome. The CRS stands for congenital rubella syndrome. Why I have taken up that first is because this congenital rubella syndrome is supposed to be the most severe among all the torch infection. This is also one more important MCQ for you to remember. Okay, right. Now, talking about rubella, when is the infection risk high? infection risk is highest in the first trimester. In fact, it is seen that among all the cases of congenital rubella syndrome, 90% of the transmission would have occurred only in the first trimester, right? Okay. Next point to remember is the clinical features of rubella. Now, whenever we talk about rubella, congenital rubella syndrome, right, we always talk about a very important triad. What is a triad? The triad is cataract, deafness, and heart lesions, especially PDA, patent ductus arteriosus. Now, this is a triad of features which you need to know about whenever we talk about congenital rubella syndrome. But please understand that this triad is seen only in 10% of affected infants, right? So that means there can be other manifestations of congenital rubella syndrome also. Now, let's have a look at the different manifestations which you need to know about, right? Majorly included in the triad: ocular, the deafness, and the heart disease. Okay, but also, as I said previously, low birth weight. Okay, neonatal purpura due to thrombocytopenia, or all associations. Okay, right. Now, some important points to be remembered for your exams, which is the most common manifestations of congenital rubella syndrome. You can see that in this list, it is 67%. That stands for deafness. Now, at this point, I want you to remember you are seeing some numbers, some like 78 and 70, right? Like patent ductus arteriosus and pulmonary artery stenosis. But please remember, this 78 and 70% refers to the percentage of heart disease which is encountered in congenital rubella syndrome, right? And you can see that as such, heart disease accounts only for 48%. It means it is still less than the deafness. So, most common clinical feature of congenital rubella syndrome is a question for you, then your answer should be deafness, right? Okay, right. Then comes ocular findings. Okay, among the ocular findings, you are seeing two things: cataract and retinopathy. Remember, cataract, even though included in the triad, is not a common ocular feature. Which is the common ocular feature? You can see it is retinopathy, right? Retinopathy. So I'm just going back and I'm going to write the answer for this, which is asked as most common ocular manifestation. Please remember, the most common ocular manifestation is in fact not cataract but retinopathy, and the typical retinopathy you get here is salt and pepper retinopathy. This is the typical manifestation of ocular feature of congenital rubella syndrome. Now here is a point to be noted, right? Salt and pepper retinopathy usually does not affect the vision of the child, whereas cataract is likely to affect the vision of the child. Okay, that point should be remembered. Okay, right. Now, next point to be noted in this slide is regarding the heart disease. They have asked so many times the commonest congenital heart disease in congenital rubella syndrome, which without any doubt, as you can see from here, is patent ductus arteriosus. In other exam, they have also asked about other congenital heart diseases associated with congenital rubella syndrome. Okay, so you have to note the others also. Most common is PDA. This is followed by pulmonary artery stenosis. I'm writing as PS, pulmonary artery stenosis, or followed by pulmonic stenosis. Okay, and this is followed by ventricular septal defect. So please try to remember these three important heart disease associated with congenital rubella syndrome. First is PDA, followed by PS, followed by VST. Right? Okay. I would also want you to remember that congenital rubella syndrome is not only associated with manifestations in the childhood, it can also have late onset manifestations in the form of diabetes, thyroid dysfunction, which has been noted in say like 20-30% of the affected persons. Okay, so diabetes and thyroid dysfunction you need to remember as late onset manifestations of congenital rubella syndrome. Now here comes a very important point which till now has not been asked in your exam, but probably a question for the future. So please make a special note of it. The most distinctive feature of congenital rubella is chronicity. That means what? The virus tends to cause infection for a long period of time. And where does this long period of infection usually going to manifest? It is in the central nervous system. Yes, it's in the brain. Okay, and the name of that manifestation is what we call it as PRP. Now, this is a term which you all need to remember. It is called as progressive rubella panencephalitis. That is the name of this PRP, progressive rubella panencephalitis. So you can remember that very easily, that it is something like a encephalitis only. It's a slowly progressive encephalitis which can have manifestations similar to other encephalitis, which you might have studied with relation to the childhood disorders, childhood infectious disorder. What is that? Yes, you might have studied about this SSP, right? Subacute sclerosing panencephalitis as association with measles. Okay, exactly the similar type of features can be present in a baby who had congenital rubella syndrome in the neonatal period. Okay, so that should be remembered. Now, here is a differentiating point which you all need to remember. Now, this progressive rubella panencephalitis is considered as slow infectious process. Why I am mentioning it like this? This is because if we talk about SSP, it is actually considered as a post-infectious process, right? SSP is a post-infectious process, whereas progressive rubella panencephalitis is a slow infectious process. Why this distinction is important? Because if you have a patient with progressive rubella panencephalitis, you can isolate the virus from the affected brain tissue. Whereas in SSP, you cannot isolate the virus from the brain tissue. Instead, you will be having evidence of only IgG antibodies only, right? But in progressive rubella panencephalitis, you can isolate the virus from the affected brain tissue. So that is why I'm just emphasizing this word. Slow infectious process is progressive rubella panencephalitis, whereas SSP associated with measles is post-infectious process. This point need to be remembered very clearly. Now, talking about the diagnosis of congenital rubella syndrome, please remember it is with the help of serum IgM antibody, which indicates acute infection. Please remember this serum IgM antibody should be tested at birth, and if it is positive, it is suggestive of congenital rubella syndrome. Now, even if this IgM antibody at birth is found to be negative, you have to retest at 1 month. Okay, you have to retest at 1 month of age. Now, what is the reason? Because in many studies they have found out that if the initial IgM antibody is negative in an infected infant, okay, after 1 month it was found to be positive. So that is why now the guidelines have come up that you retest even if at birth IgM antibodies are found to be negative. Okay, so this is something which you need to remember. The next is which can help in the diagnosis virus isolation. This is by culture or by the help of reverse transcriptase PCR, which can be done from so many specimens. The most important specimen, of course, is throat swab, which can help in the isolation of the virus. Now look at the last point I have highlighted in this slide. Detection of IgM antibody and excretion of the virus by the infected baby can persist up to 1 year of age. This is something which is very important, and it has been asked in one of the recently conducted exams also. So remember, once a baby gets infected with a rubella, okay, it can persist for a very long time. That means virus excretion from the baby will continue for a long time. Number two, IgM antibodies can persist for up to 1 year of age. This point should be remembered very clearly. Now coming to the last point regarding this, what is the prevention of congenital rubella syndrome? Why do you think this is very important? This is very important because we cannot just treat a congenital rubella syndrome, right? The baby can suffer from the consequences very clearly. So that is why prevention is the most important part in the management or future management of congenital rubella syndrome. And the only thing which helps in the prevention is vaccine against rubella virus. And you all know the strain which is commonly used in this MMR vaccine. What is that? It is strain RA27 by 3. A very important point to be emphasized here is whether the vaccine can be administered to a pregnant patient or not. Please remember, it's an absolute contraindication to administer vaccine during pregnancy because it has been found that there is a theoretical risk of this transmission of live attenuated virus in the vaccine to the baby if it is administered during pregnancy. So it has to be administered before pregnancy is planned. Okay, and after administering the vaccine, the pregnancy also has to be avoided for 28 days following administration of the vaccine. Again, the same reason I have told before. Right. Now, here comes a very important question to be answered. A lady becomes pregnant within 28 days after administering the vaccine. You know that there is a theoretical risk of transmission of virus, right? So, will you advise termination of pregnancy or will you advise continuation of pregnancy? Please remember, although I have said that there is a theoretical risk of transmission, it has been found in so many studies that if the pregnancy was allowed to continue in spite of receiving the vaccine, there was actually no problem to the baby. So if that was the question asked in your exam, please remember inadvertent pregnancy following a vaccination, that is within 28 days, can be allowed to continue. Okay, because even though theoretical risk exists, in actual There is no problem which can occur even if the pregnancy is continued. I think this point is clear, and please note this. This can be asked in your exam, right? So pregnant women exposed to rubella, okay, what can you do? Suppose she's already into the pregnancy, like first trimester, end of the first trimester, she's having a rubella exposure. What can be done? It has been found that the rubella immunoglobulin is found to decrease the incidence of congenital rubella syndrome, but it has not been found to eliminate the risk of congenital rubella syndrome. That means what? Even if you give rubella immunoglobulin, still the baby can get the congenital rubella syndrome. Okay, so it is not a foolproof that giving immunoglobulin against rubella following exposure will altogether prevent the risk of congenital rubella syndrome. It may only decrease the risk. This point needs to be remembered. So that is all about congenital rubella syndrome. We now move on to the next one, that is cytomegalovirus infection. Please remember for the exam, this is the overall most common intrauterine or the torch infection. Okay, right. And cytomegalovirus as such can have two different ways by which it can be transmitted to the baby. One is of course intrauterine, and the second is postnatal. Now this postnatal could be through direct contact or via breast milk. Via breast milk. Now this point I need to emphasize because among all the modes of transmission of CMV from the baby to the from the mother to the baby, it is via breast milk. Okay, it is via breast milk, right? So that needs to be remembered. Now let me first discuss about the other part, that is a intrauterine cytomegalovirus disease, right? Now please remember for your exams that 90% of intrauterine transmission, even if it occurs, the baby is asymptomatic. That is a point I wanted to highlight. The baby is asymptomatic. So only remaining 10% of the babies can have some manifestation, and only 5% can suffer from the severe manifestations. And this severe manifestations of CMV is what we call it as cytomegalovirus inclusion disease. Cytomegalic inclusion disease. This is what we call it as cytomegalic inclusion disease. That word needs to be remembered. Okay. Now here you can see what are the features of this cytomegalic inclusion disease. Remember, the features of what are the general features I have told you before, like for example jaundice, fatigue due to thrombocytopenia, hepatosplenomegaly, and IUGR. These are the common manifestations. Okay, but what distinguishes or what is very suggestive of cytomegalovirus disease is the other manifestations, which includes microcephaly, number one. Number two is chorioretinitis. It is not mentioned here, but you can make a note of it. It is chorioretinitis. Number three is something very important, and that can be highlighted and asked in your exam. Look at the picture. What you are seeing is you are seeing some dense white shadows here, right? What are they? They are nothing but the calcification. And look at the calcification noted in cytomegalovirus infection. Yes, it is surrounding the ventricles, right? It is surrounding the ventricles. So I will say that it's a periventricular calcification, which is one of the characteristic clinical findings in congenital CMV infection. Okay, right. So these are the clinical manifestations of congenital CMV infection. Now, one point to be noted here is that most of the transmission occurs only if the cytomegalovirus disease acquired by the mother is a primary infection. What is the meaning of primary infection? For the first time in her life, during pregnancy only she catches CMV, then only all these problems are common. Why this is important to know? Because some others may have already had a CMV in their childhood, okay, and now they are catching it for the second time, or in other words, it may be a reactivation of the previous disease, right? Okay. Now that is not associated with the high incidence of all these problems. Only primary infection during pregnancy has a high incidence of this, all the problems which we are discussing. Okay, right. Now, if they ask you the question, what about the postnatal CMV infection? Please remember, almost every infant who is getting postnatal CMV infection is usually asymptomatic. Almost 100% are asymptomatic. Then why should I know about this? This is because these infants are potentially acting as reservoirs of infection. Please remember, they can excrete the virus for a very long time, so that is why they can possess a hazard or a risk, okay, for transmitting to the other person. So that is the only thing you need to remember regarding postnatal or the CMV acquired via breast milk. Right. Now look at the next question. What is the most common long-term sequelae? Please remember for your exams, it is deafness, which is sensory neural hearing loss. That is the most common long-term sequelae. Right. Now, I said that CMV is also the most common torch infection. So that is why even when you are evaluating an older child who is having the sensorineural hearing loss, one of the important differential diagnoses you should always keep in your mind is CMV infection. Okay, the baby might have suffered from congenital CMV as a sequelae of which the child is now suffering from hearing loss. That should always be in your differential diagnosis. That needs to be remembered. Now, how do you make a diagnosis of congenital CMV infection? Please remember it is by virus isolation. This is done using the culture methods, or by detection of the viral antigens. That point needs to be remembered. What are the tests which are available? One is called as QNAT. What is this QNAT? QNAT stands for quantitative nucleic acid testing. It's called quantitative nucleic acid testing. This is done by PCR. That is one method by which we can isolate the viral antigen. Second is the detection of CMV antigen, which is called as PP65. That is also one of the methods. But the best method happens to be this quantitative nucleic acid detection test by PCR. Right? Now, the other thing which you all must be expecting is serology, that is CMV IgM antibody. But please remember that test has a very limited role in diagnosis of CMV infection. That is why I have not mentioned here. Now, next question which you need to remember is what are the samples which you can take for diagnosis of CMV infection? This has been asked in one of the recent exam questions. Please remember there are different options available. One is a urine, next is a saliva, third is a blood. And if the question is about which is the best sample for detection of the viral infection, CMV infection, your answer has to be urine, because that has the highest concentration of the cytomegalovirus. Okay, so that is why the best sample is the urine. Now, suppose the question is modified and asks you which is the best sample for screening test. Okay, then your answer has to change to saliva. Okay, screening is done by saliva. You can remember S for screening and S for saliva. That is the way you remember, right? So as I already said, CMV IgM antibody is of very limited value and usually not done most of the time. Right? Now, you have a baby with CMV infection. How are you going to treat it? The drug of choice is ganciclovir. Right? Now, for IV ganciclovir is given for a period of 6 weeks, and oral ganciclovir is given for a period of 6 months. Now, you may ask, what is the reason for giving this extended duration of treatment? It is found out that if you give it for a period of 6 months, okay, there is a considerable decrease in the long-term sequelae. What is a long-term sequelae? Hearing loss. That is decreased by giving a long duration treatment with ganciclovir. So that is why this recommendation has come. So that is all about CMV infection. Let's move on to the next one, that is toxoplasmosis. See the very first line I have written. Incidence of this toxoplasmosis increases with the gestational age. That means compared to first trimester, second and third trimester have a more chance of transmission of toxoplasmosis. But look at the next point, that disease severity decreases. Obviously, any disease, if it has to be severe, the problem should have occurred in the first trimester. So always remember, the incidence of severe infection is always higher when the infection is occurred in the first trimester. But as far as toxoplasma is concerned, it's an exception in the transmission. Means transmission occurs more often not in the first trimester, but in the second and third trimester. And when we talk about congenital toxoplasmosis, always this triad has to come to our mind. What is the triad of congenital toxoplasmosis? It is chorioretinitis, hydrocephalus. Now, this hydrocephalus is something very important for you to remember. What will be the size of the head in hydrocephalus? Now, the size of the head is large, obviously. In most of the intrauterine infection, what we read is microcephaly. Please remember, microcephaly can occur with toxoplasmosis also, but one of the distinguishing features of toxoplasmosis is that some infants develop hydrocephalus, which is usually not a finding in any other type of torch infection. So that is why I have highlighted it. It's important. Now, third finding is what you see in the picture. What are you seeing in the picture? Here also you are seeing the calcification, but they are scattered throughout the brain. So what I will write, the third finding is diffuse intracranial calcification. Diffuse intracranial calcification. This is the triad of congenital toxoplasmosis. Please remember, the calcification in CMV was periventricular, whereas in toxoplasmosis it is diffuse intracranial calcification. How do you make a diagnosis of congenital toxoplasmosis? Remember here it is again serology. Now the point to be remembered here is serology is done generally after the first week of birth. Okay, why? Because they are saying is that there could be a placental leak of the antibodies which we are going to test for. So that is why wait for 1 week and then you can do the test. Okay, right. Now here the point to be remembered is the test is slightly different names. So please concentrate on the names they have asked so many times in your exam. The first test is called double sandwich IgM ELISA, right? This is found to be very a better test compared to the conventional ELISA. It is double sandwich IgM ELISA. Now, one more point I would like to emphasize here is that there is something called as double sandwich IgA ELISA also, right? Generally, we talk about IgM and IgG antibodies, but here I have included IgA ELISA also. And please remember for the exam, this IgA ELISA is found to be more sensitive than IgM ELISA. So this is a point which has to be highlighted and remembered. IgA ELISA is a better test here. The next type of test which you need to know about is IgM ISAGA. What does this ISAGA means? I for immunosorbent agglutination assay. Immunosorbent agglutination assay. So some different names which you have to know about because these are all special tests which are more helpful in the diagnosis of congenital toxoplasmosis. So that's why I have highlighted and made you remember. In the intrauterine period, if you are suspecting congenital toxoplasmosis, you can do a molecular testing. Remember, it is not after birth, I'm talking about intrauterine period. Now this molecular testing is done with the help of the PCR of amniotic fluid. You are going to take the amniotic fluid, there you are going to do the PCR, right? Now this is done to detect something called as a B1 gene of Toxoplasma gondii. That's how it is helpful. This question may be asked in your exam, so that's why I have just mentioned this. Now, Toxoplasma is one of the very few infections where you can actually prevent with the drug and you can also treat with the drug. So that is why this question is highlighted and asked in your exams. Okay. Now, so in the intrauterine period, if you know that the mother is suffering from toxoplasmosis, which drug you can give to prevent the transmission to her fetus? The answer is going to be treatment with spiramycin. Very, very important point for you to remember. Now, after birth, if they ask you what is the treatment, it is a combination of treatment with pyrimethamine and sulfadiazine. Pyrimethamine and sulfadiazine. You all know that whenever pyrimethamine is given the treatment, okay, it has a tendency to produce folic acid deficiency. So that is why you always have to add folinic acid as a supplementation. The name of the folinic acid which we give as a supplement, okay, in this combination treatment is leucovorin. Okay, leucovorin. Right. Now, if they ask you what is the duration of treatment with this pyrimethamine and sulfadoxine, your answer has to be for 1 year. What is the reason for this extended duration of treatment for 1 year? Well, again, it is to prevent or to decrease the incidence of complication. And what complication I am worried about? Here, I am worried about the development of chorioretinitis. And you need to remember that if you give treatment for 1 year, there is a significant decrease in the incidence of this complication. And one more point I would want to emphasize here is that even if a child affected with congenital toxoplasmosis is asymptomatic, still you have to give the treatment for this 1 year duration. Again, the same reason, asymptomatic infants also can develop chorioretinitis in adolescents if they are not treated. So that is why treatment is a must even for asymptomatic individuals, and it should be for complete 1 year, right? So that is all about congenital toxoplasmosis. We now move on to the herpes zoster. Okay, right, herpes zoster or the chickenpox. Now please remember, when we talk about this herpes zoster infections, okay, it is again divided into two. One is a neonatal infection, second is a congenital or intrauterine infection. And please remember for your exams, first let us talk about neonatal infection. What is the risk period from which the baby is going to acquire this chickenpox from the mother? Remember, the risk period is within 5 days before delivery to 2 days after delivery. Why do you think this period of 5 days before to 2 days after delivery is important? This is because outside this time period, say for example, a mother is acquiring infection 10 days before delivery. What happens? She may pass the virus to the baby, but in addition to the virus, she will also pass on the varicella zoster antibodies, right? Antibodies also will be passed, and this antibodies will protect the fetus. Okay. And second thing is a very young baby, 1 or 2 day old baby catching an infection has a very immature immune system, and that also places the baby at a significant risk of actually developing the lesions of chickenpox. So that is why I'm saying the risk period is 5 days before to 2 days after delivery. Right. Now, what is the main thing here? The main thing here is they are not getting adequate protection from the mother in the form of antibodies. So that is why all these group of babies who are expected to develop the neonatal herpes zoster are supposed to be given varicella zoster immunoglobulin after birth. Okay, this is a sort of prevention from the development of chickenpox infection, right? It's a prevention aspect. Now, unfortunately, a baby has already developed herpes zoster. Then what are you going to do? Well, you all know the treatment. The treatment is going to be acyclovir. Okay, fine. Now, look at the next type. That is a congenital or intrauterine transmission of herpes zoster. Now, this is obviously going to be severe because it is going to be affecting the baby in the developing period. Okay, right. And especially the risk is going to be if the transmission occurs in the first trimester. Always first trimester has a high risk of infections. Okay. Now, here is something which is slightly different from the general rule that the incidence of developing problems due to this congenital infection in the first trimester is 0.4%. In comparison, if we talk about second trimester, I would like to put it in weeks, 13 to 20 weeks. If the mother is getting the infection and the baby is also getting it, the incidence of this congenital herpes zoster or intrauterine problem is slightly higher of 2%. So what I'm trying to tell you is that it is still early gestation only high incidence of the problem, but the point is here it is very unique that it is between 13 to 20 weeks. That point needs to be remembered. Of course, they may not highlight and ask this in your exam, but you can remember it as an additional finding. Now, you need to know what are the problems the baby is going to develop if it's a congenital chickenpox infection. Remember, it is going to be severely affected in the form of the limbs becoming shortened, or what I can call it as limb hypoplasia. Number two is that in the skin, there would be lot of scarring present in the skin, right? In the form of a zigzag pattern, and this is what we call it as cicatrix, right? The characteristic features are these two. One is limb hypoplasia, second is skin developing cicatrix or something like scars. Okay, right. And in the central nervous system also, they can have very important set of manifestation in the form of microcephaly or atrophy of the brain or the cerebellum. These are the characteristic features of intrauterine infection. So obviously, intrauterine infection is very severe. Now answer this question. A baby has evidence of intrauterine infection with chickenpox, right? And do you think that this baby needs treatment with acyclovir? Remember, for a congenital infection, already the infection has occurred. Okay, there is no evidence of treating after birth. Okay, so there is no treatment actually possible for intrauterine or congenital chickenpox infection. That you need to remember. Now moving on to the next in the herpes group, that is herpes simplex. You all know that there are two herpes simplex group, mainly HSV1, herpes simplex virus 1, and HSV2. Now, which is more commonly associated with the neonatal problem? It is usually HSV2 more than HSV1. That you need to remember. Okay. Now, if the herpes simplex is infecting the baby, it can cause three manifestations. And please remember, it is not the intrauterine infection in herpes simplex. It is usually perinatal. Around the time of delivery, suppose the mother has genital lesions and all, that time it can be transmitted from the mother to the baby. So it's usually perinatal spread for herpes simplex. Okay. So what are the manifestations it can cause? It is based on the manifestations. One is SEM, which is skin, eye, and mucosal lesions. Okay, which are nothing but the vesicles which you get in typical herpes infection. That's called SEM involvement. Next is the CNS involvement in the form of encephalitis that can develop. The next thing is disseminated infection, where not only brain, other organ systems or viscera also getting affected. It is something similar to sepsis the baby can land up with, right? So three possibilities are there. Now the time for development, it depends on the way time of development I'm talking about is which manifestation is going to develop depends on the time when it actually manifesting, the baby is manifesting with the symptoms. Remember, skin eye manifestations are like 5 to 10 days. You can remember simply, it is actually 5 to 11, but I'm making you remember 5 to 10 days. Disseminated also possibility is in 5 to 10 days. Central nervous system involvement is slightly a little later. I would put it like 8 to 16 days. Even though books mention 8 to 17, you can remember 8 to 16 days. Okay, right. So these are the different ways by which herpes simplex can manifest in the baby. Now, if they ask you how do you make a diagnosis, diagnosis is made by the help of the viral culture or by PCR techniques. Okay. Now, is there any treatment? Definitely here also you are going to give acyclovir as the treatment. Please remember here the treatment duration for acyclovir is typically more when compared to the herpes zoster. Here you are going to give it over a period of 6 months. Again, the reason is simple. If you give it for an extended duration, it is called as a suppressive treatment. You actually completely suppress the virus so that there is no possibility of virus becoming latent and causing later manifestation. Okay, so that is why long duration of treatment is given in case of herpes simplex in a neonate. Okay, right, for a period of 6 months. We now move on to a recently described or added to the list of torch infection, that is congenital Zika syndrome. You all might have heard about it. And the point to be noted is that the features of congenital Zika syndrome is still being added every day. Okay, with a lot of research coming up, a lot of new features are being added every day. But what I would want you to know from the exam perspective is that congenital Zika syndrome, one of the most important association is in the brain, wherein it generally causes reduction in the brain growth or it manifests as microcephaly. It can also be associated with cerebellar atrophy and visual disturbances. These are the problems which are being described to be associated with congenital Zika syndrome. Okay, you all know that Zika virus is arthropod-borne virus transmitted by the bite of the mosquitoes, Aedes aegypti. You all know that. Okay, right. Now, these are the problems which can occur due to congenital Zika syndrome. Right. How do you make a diagnosis of congenital Zika syndrome in a baby? Is with the help of testing with IgM antibody. IgM antibody testing is going to be helpful. But please remember, they ask you what is a confirmatory test for this congenital Zika syndrome. It is supposed to be PRNT, which is plaque reduction neutralization test. Plaque reduction neutralization test. That is supposed to be the confirmatory test in uh, congenital Zika syndrome. Remember, this is an evolving topic, so I suggest you to get updated with any latest news just before going for your competitive exams. Okay, but as of now, these are the information which you need to know. The last infection I'm going to discuss about is regarding syphilis. Now, one point I have already told you about neonatal syphilis is that now syphilis is, if it occurs during pregnancy, it has got a propensity to cause a recurrent abortion, whereas it is recurrent abortion is not an association with other torch infections, right? Okay. Now, one more unique feature of the syphilis that if a baby affected with syphilis has to develop manifestation, you can see the line here. The infection has to occur more than 4 months after gestation. Why? Because all this time I was talking about earlier the infection, greater the incidence of problem. But here I am saying after 4 months. That means say like second trimester only. Why do you think is the difference? Because remember, if you want to develop manifestations of syphilis, your immune system should be reacting to the syphilis, right? You should be reacting to that bacteria. Now, in a baby, in the first and second trimester, the immune system may not be even minimally developed. Okay, so that is why the baby may not be able to react, or the body or the host may not cause any manifestation. Okay, but a baby after 4 months of gestation, when the immune system is starting to develop, can mount an immune response. It's not a good response, but mount an immune response and can cause manifestations of syphilis. So that is why I'm trying to tell you that in syphilis alone, it's a very peculiar case that manifestations develop only if the infection occurs after 4 months of gestation. So, what is the usual outcome of a baby getting syphilis in the congenital or intrauterine period? Remember, even though I have talked about abortion, IUG, or so many things, the usual outcome is a normal or a asymptomatic baby at birth. That is the point I want you to remember, right? But that does not mean that it is going to be always asymptomatic. Definitely, affected babies, some group of affected babies are going to develop manifestations of syphilis, which is what you need to remember for your exams. So now I'm going to tell you what are the manifestations of neonatal syphilis. It can be divided into two varieties. One is early onset, if it occurs from birth till 2 years of age. Next is late onset, if it occurs after 2 years of age. Okay, right. Now, look at the picture I have put up. That is supposed to be very characteristic in the early neonatal period, or in other words, this is the earliest manifestation. What you can see, there is a lot of discharge from the nose, right? There is a lot of discharge from the nose or rhinitis, which we also call it as snuffles. That is supposed to be one of the earliest features of neonatal. Continuous copious discharge, okay, from the nose or rhinitis is the earliest feature. The baby can also develop a rash. Okay, this rash is commonly maculopapular rash. It can also be vesicular, but most commonly it is maculopapular. But one of the distinguishing features of rash in this syphilis is that it involves the palms and soles. Why? Because in most of the other infection, it may not involve the palms and soles. So involvement of palms and soles with maculopapular rash or vesicles in a newborn baby is very, very suggestive of congenital syphilis. Is a point you all need to remember. Okay, right. The next point is regarding bone. Remember, syphilis is something which is characterized by inflammation of all parts of your body, and as a part of it, bone is also affected. So, if they ask you what are the manifestations of the bone, it is all itis. Itis means inflammation. Okay, it is osteochondritis, 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 periosteitis, osteitis. All those things are manifestations of syphilis in the neonatal period due to inflammation, right? Now, what happens if the bone is inflamed? Obviously, the baby is not going to move that limb, okay? So, it appears as a paralysis, but it is not a true paralysis, right? So, this is what we call it as, I am just writing it about, this is what we call it as pseudo paralysis of Parrot, okay? This type of pseudo paralysis which you see in syphilis is called as pseudo paralysis of Parrot, right? That you need to be remembering. And some babies can also develop this condylomata lata in the perigenital regions or perianal region, like what you see in the adult population also. Okay, so these are the manifestations of early syphilis. The next point to be remembered is late onset syphilis, which is very, very important for you to remember because they keep asking this triad, which you get in case of this late onset syphilis, and that is called as a Hutchinson's triad. I'm sure you might have heard about this Hutchinson triad. What are the features of this Hutchinson triad? One is interstitial keratitis, that's in the eye. Next is in the ear, that is sensory neural deafness, and third is involving the teeth. This is the third manifestation. What is that? You are seeing the incisor which are having a notch. What is that called? That is called notched incisors, usually involving the central incisors. That is what we call it as a Hutchinson's teeth. This is what we call it as a Hutchinson's teeth. So these three are the features included in the Hutchinson triad. Now look at the fourth one, this picture. It is not included in the triad, but it is one of the recognized manifestations of late onset syphilis. Now you can see that what is highlighted, you have to look at these two pictures. What is that two areas of the picture? What is that? It is nothing but the molars, okay, right. The molars are showing a lot of these pits or indentation, right. This is what we call it as a mulberry molar. Please remember, mulberry molar is not included in the Hutchinson triad, but is a manifestation in the congenital syphilis that you need to remember. What are the other manifestations? Is that as a process of extensive inflammation, there is also destruction of the bony structures, especially the nasal septum can get destroyed, and it can give rise to this manifestation. What is this manifestation? You can see at the root of the nose there is a depression. This is because of the destruction of the bone in that area. What is this called? This is called as a saddle nose deformity. This is called as saddle nose deformity. The next manifestation which you need to remember is that there could also be anterior bowing or bending of the tibia. It is called as saber shin. Okay, it is called as a saber shin. That's also one more manifestation which you need to remember. And talking about syphilis, okay, there are some named signs, okay, which examiner might be tempted to ask in the exam. So please make a note of it. Clatton's joint is bilateral knee joint effusions. That is called as Clatton's joint. And what is the next one? It is called as Olympian growth. It is nothing but prominence of the forehead due to osteitis in the skull bones. Okay, right? So it causes prominence of the forehead. That is called as Olympian brow. Okay. The next thing is called as a Higumenaki sign, which is nothing but prominent medial one-third of clavicle. Because of the thickening of the medial one-third of the clavicle, there is a prominence in that areas, which is what we call it as a Higumenaki sign. Okay, right. So these are some of the name signs which you need to remember in case of congenital syphilis. Right. So coming to the last part, talking about the diagnosis of syphilis. Remember, there are screening tests and confirmation. I'm sure you all might have heard about some tests. What are the screening tests? Yes, it is VDRL test or RPR, which is rapid plasma reagent test. Now, if you talk about confirmation test, you need to remember some important tests. One of the most important tests is FTA-ABS. What is it? Fluorescent treponemal antibody absorption test. Second is TPPA. What is this? Treponema pallidum particle agglutination test. So these are some of the confirmation tests for diagnosis of neonatal syphilis, and the usually done confirmatory test is FTA-ABS, which you need to know for your exams. And of course, the point to be remembered is if you have a baby showing the manifestation of neonatal syphilis, it is very, very important you treat with pencil, right? Now, one more important point I would like to emphasize. Now, even if the baby is asymptomatic and you know that the mother is VDRL positive or a confirmed case of syphilis in pregnancy, you may be tempted to treat the child if the mother has not taken treatment, number one, or a mother has taken inadequate treatment, number two, or the mother has taken treatment only in the late trimester, means she has not taken treatment in the first and second trimester like that, then you are supposed to treat the newborn baby also, even if the baby is asymptomatic. But if the mother has been adequately treated with penicillin during pregnancy, there is no need for treatment of asymptomatic babies with congenital syphilis. That is the present recommendation, which you need to remember. So, as a summary, torch infections is an ever-expanding group. I have told you that latest addition is the Zika virus. Next is torch infection to affect the fetus. The infection should be a primary infection in the mother, means she should have acquired the infection for the first time. What I have told you before, reactivation usually causes less chance of infection to the baby, right? And in general, transmissibility as well as severity of infection depends on the period of gestation. In general, first trimester is the highest risk period. Always remember the exception which I have told you during the course of discussion. Now, please remember that torch infection, okay, if it is severe, can mimic many other infections, many other conditions, especially neonatal sepsis. So, always a high index of suspicion is required while evaluating these babies. Now, please remember serology should always be interpreted with caution. This is because there could be interference with the maternal antibodies also, and sometimes even though the baby is infected, as we were discussing, it may take few weeks for the antibody test to become positive. So, all these things should be kept in mind. That is why I have put up serology is interpreted with caution. Always remember, prevention is a key whenever we talk about torch infection. Not all infections are preventable, but wherever infection is preventable by means of vaccination for congenital rubella or treatment during pregnancy, like for example, spiramycin for toxoplasmosis, every measure should be done. So that is about this week's topic of discussion, that is torch infection. I hope you like this video. Please share with your friends also. If you have any doubts, put up in the comment section. I'll be happy to reply. And please don't forget to subscribe to this channel, and please press on the bell icon to get notified of the new videos as and when they are posted to this channel. So very soon I will see you in the next video. Till then, have a good day. Thank you.